Everybody, please abide. We're going to record the meeting and post it publicly. So anything said or chat, anything said verbally or, the camera part. Beware. Dr. Katchorin, we're ready to start.
Yeah, can you hear me okay?
Yes, sir.
Excellent. So it's 12 noon on March 21st. We'll go ahead and call to order the Protocols, Medications, and Devices Standing Committee. Roll call, please.
Amber Rice. Aaron O'Connor.
Present.
Brian Smith.
Present.
Esther Keys. Franco Capcho Marin.
Here.
Dark Gamer.
Present.
Heather Moore. Jason Johnson.
Here.
Josh Gaither.
Here.
Mark Sampson. Matt Shaw.
Present.
Paul Dabrowski.
Here.
Philip Cannon.
Here.
Shari Brand.
Here.
At 11, we have quorum.
Okay, thank you. So we'll go ahead and start with the chairman's report, which will be very short today. If we could take a look at attachment 3A, the attendance report. And just a friendly reminder, if you miss, what is it, two or more consecutive meetings? Is that right, Shelley?
That sounds right.
Then you will be notified if you want to continue to participate in the committee. And as far as vacancies, there are currently no vacancies at this time. And we'll move on to the Bureau report.
We need the slides up.
All right, 1 second as we pull the slide deck up. I will be covering for Chief Garcia throughout this week. So give us 1 second, we'll get the slide deck up and I will go through these. All right. Thank you to our top priorities for 2024. This is going to be continuing our strategic plan and assessments, our ongoing rulemaking process for EMS workforce development and training, the procurement of the Arizona State Trauma Registry, and continuing to promote our time-critical development entry programs, including share and naloxone lazy time, as well as the alternative destination guidance emphasis on behavioral health. As part of our strategic planning, I'll just look at the timeline here, go over this briefly. So we are currently collating all the information. So big thank you to everyone who has participated in our strategic planning process. We've had some really good feedback. I did listening sessions with that. At our next meeting, which will be April this month, we will be hosting the EMS Strategic Planning Summit. We'll show more information on the upcoming slide. If the September meeting, we will have a draft strategic plan. This will be shared for EMS Council and staff for approval. And then the goal is to publish this in November or December with the goal for the trauma strategic plan to be live in January 2025, the next 5 years. This is the save the date, the spring 2024 EMS and Trauma Strategic Planning Summit. This will be held in person with a virtual option as well. We do encourage you to come in person if possible. It will be from 10 a.m. to 2 p.m. For those of you in person, we will have lunch available as well. Reminder about our 2024 EMCT and Trauma Awards. So we did extend the nomination period for both awards programs to March 31st. We wanted to make sure that we had time for people to submit their nominations. Next slide, please. For the EMCT of the Year Award, some factors for consideration. Each regional council will vote as their nomination to the Bureau for awarding at the May EMS Council meeting. I have to say that meeting was one of the more special standing statutory meetings that I participated in 15+ years ago. So really encourage you, if you know someone who you think is worthy, please nominate them and participate in that process. The Trauma Awards, this is going to be our first year giving the Trauma Awards. We're really excited about this. These are a little bit more complicated because we have different trauma centers and different levels of separate state, and they don't really fall into the regional council format. But we do have a number of different trauma center awards in the nomination category listed here. And this will be voted on by staff outside of the Bureau. The Bureau will not be the ones voting on it. So we have a stakeholder group that will review those, and then we'll be giving out those awards at the May staff meeting. Some brief rulemaking update, some completed rulemakings included the last field practice update was in 2022. Air ambulance rules were updated in 2023. Common center rules in 2023 as well. And we just completed the ground ambulance rulemaking. Some pending rulemaking projects include EMCP certification and training, along with EMCP scope of practice. We will have a joint PMD and MDC meeting on May 1st. From 10 a.m. until 2 p.m. Food will be provided as well. There will be a virtual option as well. We do need quorum for both the committees. So just a reminder for this group. The importance of that, we are going to be looking at scope of practice or EMR, so a new certification level for the state of Arizona, along with the critical care enforcement scope of practice, which will be in addition to the paramedic scope. So really excited to add to these two big changes for the Bureau. With our experience with the CTTGs, we felt like that worked really well, having the two committees meet together rather than kind of going back and forth in our normal meeting structure. So we will have that joint meeting. We do need quorum from both groups, but we will be reaching out just to make sure you can attend either in person or virtually for that. The next steps in the rulemaking process, we had a meeting with the Education Committee last week. A big thank you to Dr. Wright who led that meeting. We had great feedback regarding both EMR as well as critical care endorsement processes. And so that is going to be in the right now, going through the internal update to the rule writing. We will have new draft rules for those that will be hopefully posted in the next 1 to 2 weeks. That will be open for public comment again. So again, thank you to everyone who participated in those meetings. We have very important, I think, critical feedback for those processes. And if you are not in our GIP delivery system, a plug for that, that is how we disseminate all information regarding upcoming meetings. So the GIP delivery, you can sign up from the Bureau's main webpage if you are not already signed up for those. So a quick update on SHARE. We are excited that we are continuing our transition of the data set from the University of Arizona to ADHS. The new AEP and CEDAR registry are both live on the Bureau's website, so those have converted over. And we are also updating resources on our Bureau DQA site as well. If you have any questions regarding SHARE, please reach out to either Julia Vinson or Adam Rodriguez about that. Next is our naloxone lead time program. Just some really exciting data on this. So we have trained currently with the training, 2,139 EMTs and paramedics in the state of Arizona have completed that training curriculum. We have 29 agencies who are enrolled in the program. We have shipped 1,336 kits out to agencies, and we have 99 tags scanned. What that means is when we actually get a kit that gets given out to someone in the community, there's a QR tag on there. We ask for the EMS providers that they scan that QR code and put in 2 data elements, the zip code of where they are and their agency. The hope is that we really can gather some of the data. We recognize that there's a good chance that kits are being given out. People realize they've forgotten to scan the QR code, but at least the kits are still getting out there in the community. So we're excited to see that we already have almost 100 kits that have been given out. If you have any questions, please reach out to Dave Hanson. His email is on the slide deck. These slides will be made available after the meeting as well. We also have a link here. This is from our Office of Injury and Violence Prevention. They have some media campaign regarding naloxone and the importance of it to saving lives. And so this is available as well on the website. It will be in the slide deck as well. National Registry, I will keep this very brief. I think the most important thing just for everyone in the group to know that with National Registry, the biggest fundamental change was a psychomotor test change. This is a very hard deadline. So this switches over July 1st. So what that means, if you have students who are currently in a paramedic program, if they are finishing in June, if they wait until July 1st to take their psychomotor exam, it will be the new format. So it's a really important thing to know. So the key thing, we just want to make sure all the training programs recognize that if you have students who are trying to decide when they take their tests, that they have to understand it's going to be 2 different tests that they take at June 30th or if they take it July 1st. That is some of the key thing. There's some other updates to the 2025 NCCT model. There was some delay in terms of that time frame for the ongoing certification requirements. And there's also some meeting resolutions which are linked to the slide deck as well. For our trauma registry system update, I will cover this briefly. Our current vendor for our trauma registry has a sunsetting their program. And so we do need to get a new trauma registry for the state. We are getting ready to start the RFP process for that with the goal to complete that by July 1st of this year and implement the new trauma registry July 1st of 2025. And just a brief summary of our dashboard, just a reminder that Bob Fulnax and her team have put together some excellent dashboards. And these are available on our website if you'd like to review any of the data that is there. And I think that's it. All right. Next, I would like to welcome some new bureau staff. So we have Karen Barnes, who's new COS auditor. Dave Hansen, who I introduced before, as our Care Grants Project Administrator. Mike Hamilton, who's our senior GIS analyst. And we have two new investigators as part of our enforcement division, Mitch Adair and Jeff McGrath. And I think to not to leave behind, I have covered that, and I will hand it over to them to cover that. All right, that is it. I will hand it back over.
All right, thank you so much, Dr. Bradley. The next item on the agenda on our discussion and action items is to discuss, amend, and approve draft minutes from November 16th, 2023, and that should be attachment 5A. Motion to discuss, please.
So moved. Amber.
Second.
Thank you. Any comments, changes? Hearing none. All those in favor of approving the minutes as shown, say aye.
Aye.
Any opposed? Abstentions? All right, the motion carries. Thank you. Next item is to discuss Articles 2 through 4 EMS training and certification rules from the March 14th meeting. Motion to discuss.
So moved.
Thank you.
I'm sorry, I didn't catch. Matt and Josh for the first, second.
Yep.
Right.
So I think I can just give a brief recap on this. So the Education Committee hosted a meeting last week to really get feedback from the community regarding Article 2 to 4. So this is certification and education rules. We don't have the whole rule set open, but specific to EMRs and critical care endorsement. We have really good feedback from a lot of participants across the state. So a big thank you to everyone who participated in that process. I got a little bit additional feedback. Thank you, Dr. Gates, for providing that as well. Dr. Johnson is kind of bringing up some questions. So the hope is to get a new set of draft rules posted within the next 1 to 2 weeks. Those will be open for public comment again. We really do encourage everyone who's interested in this. This is what allows us, number one, to have specific requirements for critical care endorsement for initial certification, recertification, as well as training program, as well as how to get in certified if you're potentially working elsewhere as a critical care paramedic. So we had a great discussion in that regard. And then for EMR, we do not have the ability currently to certify EMR, but the goal of this is to create standards for training programs in the state for an EMR training program and what is required for that. That is a summary. We just wanted to give everyone in this group kind of a little bit of background of what that process is, the importance of that if you're interested and would like to participate in that public comment section. Further,
Thanks, Dr. Bradley. Anything else?
not unless there's anyone in the room who had anything else to add to that.
Okay. No action on this item, correct? Today?
Correct.
All right. Next item, discuss Article 5, scope of practice, upcoming special meeting coming up on May 1st. Motion to discuss.
So moved. Amber.
Seconded.
Okay. I think just as I mentioned before, this is going to be as a discussion on the combination of adding an EMR scope of practice as well as a critical care endorsement. The EMR is a little bit more simple because there is a national curriculum and scope of practice for EMR and the national scope of practice for EMS providers. So that one I think will be a little bit more simple to review and implement. The critical care endorsement is potentially a little bit more complicated or complex, as there isn't a set national scope of practice for this. We are doing our best to kind of query different states' versions. Some states have certification, others have endorsement, and put together something that will look like a draft version that will go out well ahead of the meeting for people to review and make sure that there's time to look at that. But just to give a little bit of background, the importance of participation in this group, our hope is as part of the rule writing process, we do need this to be approved and in place as a scope of practice for January 1st, 2025. And just with the way our meeting cycle work, we don't want to get into this situation where we are kind of July, PMD discusses this, it then goes into September, and something gets kicked back, we will miss that deadline. So that's why we were trying to get everyone together. So a big thank you ahead of time for everyone who's going to participate in that. If you have a conflict, please let us know. Like I said, we will have both the in-person and virtual option. We will have food available. I will not be in charge of ordering food, so I clearly failed twice now. I'm going to be banned from that.
I don't want to do it either.
Yeah. But we will have food available and drinks to make sure that this is going to be quite a bit. I'm excited. I think this is something that it's long overdue in the state of Arizona to have a critical care endorsement, and it's something that I've asked for many years. We finally got approval as part of the rule writing process. So I see some head shaking in the room. So a big thank you for everyone ahead of time for that. Any questions about that process?
Okay, hearing none, thanks, Dr. Bradley, for your leadership on these very, very important advancements for the state. The next item is letter D, discuss addition of finger thoracostomy to the paramedic scope of practice as an STR skill. This is summarized on attachment 5D. Motion to discuss.
Motion to discuss. Amber and Max.
Thank you.
Where would you like me?
Under a green lift tile.
That's green or tile. Okay, yeah.
Oh, you need that.
Just real quick. There's just a few. I didn't start by introducing a green list tile. Okay. What's that? Thank you everyone for giving me the opportunity to present the proposal for your consideration. My name is Carol Davis. I'm one of the trauma surgeons at Flagstaff Medical Center. I'm also the Arizona Trauma Association president, but I'm speaking here on behalf of like my personal views and opinions, and also with the support of Flagstaff Medical Center, Northern Arizona Healthcare, and Guardian Medical Transport. And just had wanted to talk about adding finger thoracostomy as a scope of practice for paramedics. And this has been shown to avoid the complications of needle thoracostomies. The problems with needle thoracostomies, we all know, 50 to 65% complication rate. A lot of times they don't even enter the thoracic cavity, whether it's anterior location or lateral chest location. They can become clogged or kinked, clots and bleeding. There can be overpenetration. They can become dislodged, and they require recurrent applications. Actually had a patient that was brought to me yesterday after a long transport that had 4 needle thoracostomies, both lateral and anterior. And so we're teaching in ATLS about finger thoracostomies, and there's many other states and organizations that are doing finger thoracostomies in Europe, also in Australia. And then Washington, Texas, and Virginia all have pre-hospital paramedic scope of practice for finger thoracostomy. Is that not opening up?
I do.
Sorry. I can continue to talk if we don't need the fancy slides. I just had a few pictures and, so the finger thoracostomy, there are several pre-hospital states that do approve that. And there are some data that shows that it's safe and efficient because you're not putting a tube in, then you don't risk injuring the lung, causing more bleeding. It takes less time. It's it's effective. With a finger in the thoracic cavity, you know that you're in the thoracic cavity, and can confirm, there we go, and can confirm placement, only about a 10% complication rate. And essentially the complications were associated with either user approach, bleeding, injury, or infection complications. So only about 10%. So I think I kind of ran through all of my slides. But just as an example, so fifth intercostal space, lateral chest wall, a small incision, curved clamp, pop into the pleural cavity, spread, and then insert finger with a sweep. So very efficient and effective. And question?
Yeah, can we rewind the slides? There was one that kind of went a little quickly there. Yeah, there we go. Any idea when these other states went online with their processes? How long they've been doing it? What their experience has been?
So when I look at, like, for example, Texas or Baylor, I think it's like 2013, so probably a little more than 10 years ago, had introduced this. And they do recommend the, special training and then ongoing training through competencies and case reviews. Do you want to say something?
Yeah, this will be my question.
Okay, that's your. But for example, so in Texas, for about, more than 10 years. And I know in Europe and Australia, I think primarily because in their EMS systems, they also have a physician involved in their EMS system. So they have been doing this a lot longer, and they also have publications out there. And so then it was like physician directed paramedic involvement, but then that evolved to paramedic performing these procedures.
I can maybe speak a little bit to this. I didn't know this was actually going to be on the agenda, but we had the Air Medical Physician Association meeting right before NAEMSP this last year, or in January. They actually talked a lot about this from the air medical side, and they had a lot of research that supports this for paramedics. But it's specifically saying not doing the needle because, especially with the obesity epidemic, the needle just don't get in deep enough. And then not putting a tube in, you're not worrying about getting the liver or getting something else. So I know at least that organization is a big proponent of trying to get paramedics across the country to be able to do finger thoracotomies.
I have not seen any evidence from like ground-based paramedics. Like I've used referencing critical care paramedics in helicopters. I'm not aware that there's a great amount of literature on outcomes and adverse events happening with.
And there is, for ground, that Baylor protocol that I was talking about is for their ground-based crew. And a lot of it does depend on the transport time and the arrival time. So, in an urban city, the ground crews may not need to perform these, but certainly in rural areas and longer transport times.
That Baylor study statewide data, or this is a single agency?
I don't want to misspeak.
Okay.
This is unique in that they
Very
don't
different.
have, like, any medical director that they can make different scopes of practice. So I don't think that you can equate something in Texas statewide.
That's what I'm saying.
So
I think
they
that
don't have that.
one agency may have like this special thing that they do, and they might do it very well, but I don't know that data could apply broadly at all to like a generalized population of paramedic.
And I think it's, sorry if I need to piggyback with that. It's kind of like to your point too. It's like if it gets approved, right? Doesn't mean that everyone in the state has, like every medical director has to sign off on it. If you find that as a medical director, your region would benefit from it, then it can kind of be utilized in a similar aspect.
So great presentation. Thank you very much for coming down. I think this is a good thing for some integration. I wonder if this may not be the thing for our critical care paramedic scope of practice and not our general paramedics. And I'll use myself as an example, right? In Southern Arizona, we have more than 1,000 paramedics. Getting 1,000 paramedics to recognize a tension pneumothorax as the indication for needle decompression is very, very difficult. Our greatest challenge is excessive use of needle decompression in patients that don't need it. I think my concern in my system, and again, you see one system, you know one system. This is a pretty big procedure and has the potential to have a lot of complications in patients that don't have a pneumothorax. I think for my system, I would be more concerned about the complications of doing this in a patient that didn't have a pneumo than the complications of not doing a needle or having the needle decompression fail. I think with adjuncts like ultrasound, with advanced training, it becomes a much lower risk procedure because you're selecting your patient population correctly. It's a thought for us.
And I agree with Josh, and that's what I would say. I would totally support doing it for critical care because I would love to see this on helicopter and flight-based paramedics being able to do the finger thoracotomies when they're on scene flights and things like that. And I would have a hesitation with some of the paramedics I know that I wouldn't feel comfortable with them doing ground-based.
What about weather related, like the air crew can't get there because of weather. And so the patient has to go by ground or, that's the only crew that's available. They're the first responders and certainly in cases of tension pneumothorax, but then what also traumatic cardiac arrest. The patient's either dead or we get some resuscitation.
I agree. Like, I think that definitely fits into the critical care paramedic scope, but flight companies cannot always get in when weather is bad, right? And there's large parts of our state that have very prolonged ground transports when flight companies are not able to fly due to bad weather or the aircraft just aren't available. I think the group of patients that are going to get a finger thoracotomy are the patients that are already dead or nearly dead. The traumatic cardiac arrest that we're going to finger as ruling out H's and T's, or the patient that's about to go into cardiac arrest that we're trying to relieve a tension pneumothorax. It's the same thing as a surgical airway. We're not surgically cutting people's throats every day, right? But it remains in the scope because there is this subset of patients that do benefit from that procedure. Again, like, it is a high risk. It is a new procedure, and maybe it's a high risk procedure. Though, if the patient is almost dead, maybe it's less high risk. But again, it doesn't need to be. If it's approved to the state, it's up to each individual medical director to approve it for their subset of paramedics or not their subset of paramedics. And I would just say I do think there's value. Certainly in the rural parts of the state, certainly air resources who are a higher level of care can't get there. And while this might only benefit a handful of patients every year, it is a handful of patients that we are benefiting.
I think with like teeth review and ongoing like education, and I think I'm not obviously an EMS director, but I think it would give people pause to, okay, a needle versus making a little bit bigger incision. And so it may be less utilized or an adjunct if they're having difficulty with needle.
To echo some of what you're saying, there's no doubt, right? And the critical care paramedic should be involved in there too. And then similar idea, right? Just because it's your medical director says, hey, to go, you can then further fine tune it into whatever protocol you deem it appropriate. Because it's like in certain visions, it's not like, oh, this patient's talking to me, it's slightly short of breath, let's proceed forward. It really is kind of in those ideas. Like, if we're willing to have paramedics take a knife to the throat, I really don't see how this procedure is any higher risk, especially in patients who we are seeing are actively losing pulses or have just lost pulses. We know we have plenty of data kind of showing that a finger thoracotomy works significantly better than a needle thoracotomy for these kind of patients. So it would just be, I have my opinions. I'm trying to kind of rate it in a more objective approach, but I just feel it would be in the benefit of our population to have that available in those situations. And clearly I'm biased because I do have more of a rural population that I often work with. So I can very much hear also when you're 2 minutes from the trauma one center Or when you're 20 minutes away from a trauma one center.
Shelley, I saw a raised hand online.
Yeah, that was me. My name's Dr. Jerome Rogich, also one of the FMC docs who does EMS stuff in Northern Arizona. Just want to put in sort of a word of support for this. I know that there's some pushback, especially from some of the people who operate in more urban areas and who have a lot of paramedics, but we fundamentally operate in a different environment up here. And having seen some of the complications from needle decompression and the long transport times and weather issues that we have up here, I think that it would be a greater benefit than harm.
This is Franco. Another thing to consider is sort of the resources to stand up something like this. It's very interesting to hear the comparisons to cricothyroidotomy procedures, and that's a point I hadn't considered. But I found an article that was published back in 2014 that summarized the rollout of this procedure for Montgomery County in Texas at Baylor. And just kind of looking at their summary here, their initial training included a 4-hour didactic plus a anesthetized swine model for every provider. And then they did a follow-up training biannually, so twice a year, again with anesthetized swine, because they agreed that this was high risk, low frequency, and of course a commitment to 100% quality review. But you get into this frustrating paradox where everybody, I'm sure, agrees that this would benefit a rural patient, sometimes very limited in their resources to save a life in those kind of environments with long transport times, and question whether or not critical care paramedics would be available, flight teams would be available. But the paradox is that those agencies are the ones with the least financial resources. And looking here at Montgomery County's article, one of the primary points that they stipulate is, quote, ensuring that the service is financially committed to the appropriate initial and continuing education. And it's just hard to square that.
I think that's a really good point. We did some brainstorming about what training for this sort of thing would look like if we were to roll it out, and using our flight program as a model. Looking at them now, they're not using anesthetized swine anymore. I think they're primarily doing cadavers or other high fidelity mannequin. But I think, certainly finances do play a role, just like they play a role in anything. If your agency is unwilling to invest in airway education, your innovation success rates are going to fall, right? Your ability to have a good first pass success rate is low. There is a financial burden, but I think it's up to ultimately it's up to that agency and their medical director. Do we have the finances to go about this, or do we not? I would agree, biannual training is probably very important, and certainly that upfront cost is going to be a lot. But if that agency is willing to take that on, I think we should give them that opportunity to be successful.
I'll just make one statement as a reminder for the committee that when we add something to scope of practice, any medical director can choose to approve this. So you have to keep in mind that not all medical directors operate equally and have the same level of oversight and training. So that is something that this committee has to keep in mind. Is that there's great variability in medical direction across the state. And so when something is added to scope of practice, it is then available for any medical director to approve. And so that does need to be a part of that consideration.
Well, it's going to be my comment too. I fully believe that Guardian can do this. I trust you guys. The 20 most engaged medical directors in the state are in this room. The ones I'm worried about are the 20 that aren't. I'll just throw this out there. We as medical directors are constantly put under pressure to do something new, exciting. And whether we want to acknowledge it or not, because we are paid professionals, people can go elsewhere to get a medical director that will. That's my hesitation to giving this to everybody. Is it safe for you guys? 100%. Is it safe for my very urban fire district? No. It shouldn't be done. And I have some worry there.
But to the same extent, then, right, that they still have surgical strike available, if you felt that was unsafe, if you felt RSI was unsafe, you would take it away.
I just
No.
you are.
We don't.
No, exactly, right? That's what I'm pointing out. So in the same way that it's available, you can still say, I don't feel safe with it. How is this any different?
I think it's different when we're trying to cross the state. That's what I could.
And I think the
For sure.
incidence of the need for this is quite low. I think, as an example, I went back through with a resident, we looked at the NEMSIS data going back 10 years on nasotracheal intubation data across the country. It's horrific. Yet it's still in our scope of practice. I mean, we still allow people to do it because it's something we've always done, which, I mean, fine. I think arguments can be made that with other things available and limited, opportunities for training, that training for something very complicated takes away from training for something else. So we often will, we don't do regular training on nasotracheal intubation because we need to put our educational time elsewhere. And I think the unintended consequence of adding additional things to the scope of practice is that you take away from things that are other life-saving treatments, so that you end up focusing your time training on things that maybe are life-saving in a very select few people. So without knowing the real incidence of how often this is needed, I think it's really difficult to say that it's necessary to add it to the general paramedic scope of practice. I just have a huge hesitation with that, not knowing really how often this is truly a life-saving procedure. I think it's a little bit easier to argue on the Craig side. I think it's easier to know when it is and when it isn't needed. I think this is much more difficult to diagnose in the field. So, I mean, I'll leave it at
We have
that.
a raised hand. We have a raised hand online.
Yeah, this is Dr. Rogic again. Just a question for Dr. Davis. I was wondering in her preparation for this proposal, if she came across any sort of structured trainings or what that training burden looked like for states that had been doing this already.
Like I said, the Baylor protocol that was previously referenced was probably the most detailed. There were some other ones. I don't know though that it was statewide. So I couldn't say. I know though that like some limit it to just resuscitate, like for traumatic cardiac arrest patients, and then others have a much wider indication where they'll do it for not only tension pneumothorax but flail chest. And I don't know that bit larger scope would be appropriate. But that's also like there are some that limit the indications to just traumatic cardiac arrest, and others that then include tension pneumothorax or a more broad indication.
Do we even have a way of delineating that we could do it to allow critical care?
Yeah.
Right.
That's so critical care endorsement will be its own essentially column on the scope of practice. That's the May 1st meeting is we're going to look at adding essentially a new to the left EMR column. Then there'll be DMT, ANTI, paramedic, and then critical care endorsement on the far right.
That, in my opinion, would be a good way to bridge into it in the state, and then we could track it and see how we're doing with our critical care medics, the ones we trust, rather than rolling out to everybody all at once. We could say, all right, we're going to allow our critical care medics and then get some data. And if we say, hey, they're doing this right, they're doing this appropriately, then potentially in the future, we could roll it out.
And is there currently data on like nurse involved finger thoracostomies or?
Yeah, and that's the one that was at the air medical position, and they said it's much.
Bronco, can you hear me?
Yes, I can.
Wonder what's going on there. This is great
Is-
discussion. God, I'm so torn about this. One of the things is the itinerant population of paramedics. And if you just bring it into scope of practice, then say one medical director trains on it, then that paramedic moves somewhere else.
Mhm,
And
mhm.
then all of a sudden you've got a cadre of people out there.
Yeah.
You know, I
Yeah.
think the critical care
We-
paramedic pathway makes more sense.
Yeah. It looks like they're working on audio
Sir,
now.
we're
We're
having
probably
audio
still
issues in the
being-
room. So I'm using my iPad now. This is reminiscent of January. On the phone, Dr. Casperman, can you hear me now?
Yes, I can.
Can you hear
Can
us?
you hear me?
Yes, we can hear.
Yes,
Okay. All right. Sorry.
yes,
We're using
confirmed.
my iPad now. So we're going back to passing this around like we did at the last meeting. So Dr. Gamer, I saw you were speaking. We did not get to hear all of that. So if I can go, I'll hand it back to you, Franco. And then I heard, I think both of you speaking, but the room could not hear you. So
Sure. Sure. Dr. Gamer, would you like to go on record with your thoughts, or shall we move on?
Sure. Thank you, Franco and Gail. I'm really torn about this. I'm sure it makes a lot of sense in the right hands and in specific parts of the state, with like others who serve urban areas as medical directors. Obviously, the training burden would be a huge thing to take on in an urban setting. So I would then seem to support bringing it in as a scope of practice, but we have such an itinerant paramedic workforce, and I'm afraid if one group of paramedics got trained and then moved to a different system, they'd still think, well, this is something I'm permitted to do, and then we might have procedures done that are not blessed by their medical direction. So I think what I've heard that makes the most sense is that this pathway through critical care paramedic to get some experience and go from there. Thank you.
I guess my only concern with that is if a paramedic did that right now, they're not allowed to do that currently. Like if I go down to work for Dr. Gaither, my scope up in Flagstaff is not my new scope down in Tucson. I presume I wouldn't be RSIing and doing all sorts of very cool things that we can do up in Flagstaff. Right, and this would be no different if we were doing if I was doing a finger thoracotomy up here and I went down to Tucson, Josh would say no, and then I would have to listen to Josh because he's my boss. So I mean, that's my perception for everyone in the state, right? A paramedic can't be trained in one area.
I get what you're saying, but that's not necessarily true. We've had medics say, "Oh, I was trained in New York to do this, so here I go." And then so I can take that back when somebody has something bad happen. They do that.
I mean, I'm sure that's probably true, but they
shouldn't.
can't, right?
It shouldn't.
I mean, that's a much bigger administrative issue if we're not adequately overseeing.
Our audio is over here now, if you wanna.
I guess maybe wanted to pose a thought or a question about the concern about the training burden, and certainly live models are more expensive, but would this just be an adjunct, an extension to your already current practice of needle decompression training and maybe not necessarily every person, but selected people. So just as an extension of your current training, because it's very similar locations and techniques. Slightly
And to add on to that and add on to your, like, we've been utilizing 3D model printing. That's been fantastic for different kind of like things that sometimes require cadavers. It's hard, right? And I very much hear you, right? Like, I have 16, 17, how many agencies do we have to do today, unfortunately? And they all
17, 17.
yeah. And they all have different abilities. They all have different things, but it's still my responsibility as medical director to learn what they each can do. Not all of them are having the same abilities within my own kind of guidance too. So I very much do hear that point, right? We blanket give everybody every single procedure that's available, right? Like RSI is the easiest example we can all kind of like have like and experience with. So I do hear you. I do see that, like, critical care can't even be the easiest way. But I have a hard time when it's not even on the work. We don't know when that's going to be going into effect. We are like, our job as medical director, I do hear your point. We are paid professionals, but we also have to do what we think is most right. And I very much respect what you all do. I do appreciate it. So I just want to say thank you. But I have to also speak kind of from what I feel is important too. And just say, it's like, hey, it's like, I know I have teams that I'm going to be like, hey, let's work up the thoracotomies. And I have other teams I'm going to say, come join this airway training. Come join our training we're doing here. Show me what you can do. And if we pass those benchmarks, you can have it too. And if we can't pass those benchmarks, you can't have it. We have to be able to have those kind of discussions with our teammates.
Thank you for the comments, everyone, and Dr. Davis in particular for taking the time to put some slides together and pass along this information. Does anyone have any additional final pressing comment before we move to a vote?
Brian's hand up is in the room.
Point of order, because it's not on here for today. The best I can tell. It says discuss condition, not discuss and so.
I didn't quite catch all of that, but I think what I heard was that it was just an item for discussion. Is that correct? So no vote necessary?
Can we amend the motion?
No,
Add it?
this is has to follow open meeting law and it's not on the agenda.
And that's my fault, I'm thinking.
Could
This
we
could-
add it to the meeting and bring it in the back later to the critical care? Because like I said, I'm all for getting into the critical care scope so we can start seeing some data on it moving forward.
So we can definitely include it on the May meeting with the caveat that we have to complete an entire EMR and critical care endorsement scope of practice at that meeting. So we have 4 hours. So I just, in terms of time frame, I would say, yes, we can talk about it further there, but maybe have the discussion here. So that way we're not kind of having that conversation there just because we have to knock out that from a rule writing perspective. We have to have that critical care scope of practice has to be ready to go January 1st.
So with regard to the action item, Shelley, can you offer some guidance in terms of discussion versus vote?
Yeah.
Or actually, I'm sorry, before we do that, Sherry Brand has her hand raised online.
I just had a quick question, like from the EMS training standpoint, like for the paramedic programs, like I don't think we're teaching it even. Whereas, you know, the comparison to Crike was brought up, and as a national standard, Crike is taught. And at least they get the basic training of it. I'm just bringing that up because I could tell you in my paramedic classes, we're not doing finger thoras, but we are doing Crikes. So just as a point when you were using that as the comparison for the basic training in it.
Yeah. Thank you. That's a great point as far as it being not something that's included in the original training. So Shelley, what are the?
We had
what's
a point of
consensus in
order
terms
in the room from Brian Smith.
Yeah.
That this item is not, I did not put approval on the agenda. So I apologize. And we can add it to the May 1st agenda for a vote from both bodies.
Okay.
EMD
Okay.
and-
But
All right.
but Bronca, I will say we do have some time. And I think this is the last item on the agenda. So probably good to kind of maybe if there's any further comments, have it here just so that we.
I contribute as far as education, because we do with the flight crews and we do with the nurses, and you have nurses who have never done it before ever, and maybe they've worked in the ICU or the ER, and now they're becoming flight nurses. There are good models, and actually we'll use those mannequin models, and then we'll buy ribs from the store and then take those and use them. So I'm not worried about the training part of it. We don't need to have live pigs or anything like that. It'd be cool, but but I don't think we need it. But my concern is the same as what Josh has mentioned is there's 20 or so medical directors who are really involved, but I've also met a lot of medical directors who just say, give me a check and I'll sign whatever you want. And then they just turn people loose. And that's what scares me. And I don't want, if this is something that I personally actually completely agree with this, when it's done correctly,
I don't want it to get screwed up by us proving it, and then we have some bad outcomes. We say, okay, we're pulling this off. So I would prefer to roll it out through the critical care people we know and trust, get the experience, get it down, get the training established. Then we have some data to document, hey, we're not killing people. And it's actually doing well, and then we could potentially roll it out.
Any additional comments?
Is it worth, or is it possible to do like a test vote to decide if it's even worth bringing back on May 1st? I don't know.
As long as we're not officially, as long as we're not officially voting, yes. We could do an unofficial roll call vote.
Yes. To know who is the right. Well, if we did it, we split it, say, would you be one vote that says, would you be able to approve it for all paramedics, and a separate vote, would you approve it for critical care? Hypothetically. Hypothetically. That way we know, because then we would know which way to address it. Because if you're like, nobody's gonna agree with this for all paramedics, but we do have a majority that agree for critical care, then yeah, it's worth putting into the new protocol.
I'm pretty happy to be transparent. I would fully support critical care, not the rate.
Me too. Me too. Hypothetically, purely hypothetically, yes. Hey, Garth and those others who are online, theoretically, would you be okay approving it from a, not all paramedics, but starting with just the critical care paramedics being willing to give them that scope of practice?
Absolutely. Unofficially.
Unofficially.
Yeah, I'd support critical care.
Halfway, kind of move on.
Anything else from the group? Gail, since I'm not in the room, can you confirm, are we ready to move on, or?
Yes, we are. Thank you.
Okay. All right. Thank you again to our colleagues up in Northern Arizona. I would echo some of Josh's comments that, you know, obviously you guys run a tight ship up there and are an example of, you know, best in class service in Northern Arizona. You know, it would be to the state's benefit to be able to mirror that statewide. And thank you guys for your time. Next agenda item, is there anyone want to share any agenda items to be considered for the next meeting? If you do, please send those by email to Shelley for addition to the agenda. Any call, we'll go ahead and leave open a call to the public. And hearing none, then we will go ahead and adjourn the meeting. Thank you. Oh, I'm sorry, before we do, excuse me, I forgot about upcoming events here. Number 8 here on the agenda, as you can see there, a list of upcoming events, including the very important May 1st Article 5, Table 5.1 meeting, both virtual and in person. And then we have several conferences through the summer months as well. And those calendar items are available online. The next meeting, again, we have a special session May 1st, 10 a.m. to 2 p.m. at ADHS, as well as virtual access. And then the next regular meeting of PMD will be July 18th at 12 noon. And with that, we'll go ahead and adjourn. Thank you, everyone.
Thank you.
Thank you.
Thank you.